Thank you for hosting me here, and I'll try to walk you through some of the work that we do in our lab, and I try to skip the equations and the math, but believe me, there's a lot of science behind what you see here. Well, if we talk about, see, does it work? When we talk about medicine, then this is how surgery would look like if we don't have science. This is a Rembrandt from the 15th century. I'm not sure who wants to be a patient in such a scene. But it's interesting to note that the first hospital was established actually around the same time that the first industrial revolution took place, which means that there is a lot of connection between technology and medicine, obviously. And what you heard before, the talk that you heard before, is only doable because of technology that is developed by people like us. So I'll try to walk you through my career and what I did, or as I call it, my time tunnel. Let me see if maybe the other pointer works, because mine doesn't work. Of course, in the dry run before, everything worked. Well, it insists not to work. Anyway, so walk you through my time tunnel of work. I started my work in surgical robotics back in the 90s during my PhD work, where I work on robot for spine surgery, as you can see here. A company named Mazor was a spin-off from the university. And the whole idea of the robot was to help surgeons to put pedicular screws in spine for spinal fixation. You heard the previous speaker about radiation, and orthopedic surgeons that do spine surgery really expose themselves a lot. And I really identify with him because I had to wear the vest, this lead vest, for many, many hours in the operating room. So the whole idea of the robot is that to put the screws inside the spine for spinal fixation, you need to be very accurate. Actually, you have only 1 millimeter gap between the spinal cord over here and where the screw enters the pedicle. In a normal surgical procedure, you put about 6 screws, and the world statistics says that 1 out of 10 screws penetrate the spinal cord, okay? And 5% badly penetrate the spinal cord, which means that the patient will not walk anymore. Now, the idea was that with preoperative surgery, with CT or MRI scan, you can actually design the surgery in the virtual world, decide where to put the screws and in which angle, and then intrasurgery, you attach the robot to the patient's spine, and then using some kind of a registration procedure, in other words, telling the computer where the robot is in real world and the robot where the virtual world is, the robot is then guided based on the preoperative planning. The company was launched through the Technion. Worldwide, more than 100,000 screws were inserted with 100% success. The company was just bought a year ago by Medtronics for $1.6 billion. Billion, yes. And then I moved to Pittsburgh. I worked in a computer-assisted surgery with Tony DeGioia, one of the leaders in computer navigation. And we did a lot of work on computer navigation in orthopedic surgery, hip nav, knee nav. This is the golden time of computer navigation for orthopedic surgery. Here you see Tony replacing a hip joint using computer navigation. It's almost like GPS in the operating room. The computer and a set of cameras track everything in the operating room and tell him where to put the implant and in what orientation so that the joint would not dislocate after the surgery. So you see that Tony has only to put the green circle centered around the red circle, and he knows that he's in the right place. So these were the golden age of computer-assisted surgery, hip nav, knee nav, and then brain surgery. But it turns out that there was a movement to try and do these surgeries, what we call them radiation-free, which means that patient would not have to take an X-ray or CT pre-operatively. And just during surgery, you palpate several landmarks, anatomical landmark, and use some kind of an anatomical atlas or statistical atlas of patients with pelvises, and we'll do the surgery, no radiation, radiation-free. We're going to save a lot of money to the health system because no need for CT or MRI. Obviously, this was not such a very successful decision, and there were many dislocated joints post-surgery. When I say dislocated joint, it means when a patient tries to sit on a chair, his joint just pops out, dislocates, because mechanically, the orientation is wrong, and there is a bone-to-bone contact or something like this. So what we did is we did a large study and some kind of kinematic model where we tried to quantify, these are the landmarks that surgeons were asked to palpate, the pubic tuberculus and the iliac spine. And we built up a statistical model or kinematic model of what happens if we are missing these points. By the way, when I say palpating, they have like a needle, and they had to somehow touch and assess where this point is. So I said, what if you are 1 millimeter off, 2 millimeter off? What would be the effect of the location of the implant at the end of the day? And this was a very nice paper, highly quoted, that showed that after you use all the mathematics and the kinematics, we provided the surgeons a map telling them that, hey, if you're only 1 millimeter off, you're actually going to be 5 degrees off putting this implants, and you're going to be having a patient dislocating his joints. And eventually, history or experience did itself, and everyone is now back into CT-based and MRI-based joint replacement surgeries. When I was there in Pittsburgh, it was right after 9/11, and 9/11 was the first time when robots were sent into buildings to try to allocate survivors and tell search and rescue people whether it's safe to go into buildings. And for those of you who know Carnegie Mellon University, this is the shrine of robotics. And we were asked by DARPA, by American search and rescue teams, to try to build robots that go inside the buildings and help them find people or check whether it's safe to go inside. So we started building robots that looks like, we call them flexible robots. This was like 16 years ago. And they look like elephant trunk, and they have a camera at the tip of the head of the robot. And here we did some kind of kinematic tricks where we rotate the image as the robot rotates, because everything should be rotated, okay? You have a free-flying camera, but if you know the kinematics, you can rotate, you can compensate for the camera rotation, and then you can send these robots and look in places where it's hard to reach. So this was our first take, and then I came back to Technion and started to say, hey, why attach these flexible robots to a base, a mobile base? Why not let them go wild, go free? And I started building snake robots. These were snake robots that were printed. This was in 2007, one of the first printed robot ever. And to make these robots, we had to bring snakes, real snakes, to our lab and do motion capture for snakes to try to understand how they locomote and model their motion. And you see here some of the snakes, some of our models. And as I said, then we build our snakes, and this is our first take of the snakes, with skins, without skins. They can crawl, they can roll, they can stand up, and actually they carry any sensor that we put on the snake inside the buildings, and they ease themselves just like a snake in nature without moving the environment too much, because don't forget, this is a building that was collapsed, and it's not that safe to go inside and to move things around. Maybe there's going to be extra collapse. So you want to build a robot which is very, very gentle with the environment, just like a biological snake. So these are the snakes that we built. Now, to make this snake work and roll, it's not that simple, it turns out. And the motion planning is very complicated. Actually, if you compute the search space or the options for motions to make the snake work, by the way, this snake has 20 joints, okay, 20 joints. So you have to think how to move 20 joints in space. This is something that human cannot imagine in order to get a meaningful motion. Then if you calculate the options that you have, it's about 10 by the power of 3,608, which is quite a lot. If you look at the horizon, you see about 10 by the power of 80 atoms. So you just imagine the complexity of this problem. So this was, I said, in 2010. So one of my students suggested that let's build a digital twin of our snakes, and digital twin is something very popular now in industry. So we dynamically modeled our snake into computer software, and then we did motion planning for the physical snakes and copied the motion, again, refined our model in the computer animation, so that at the end of the process, we had a quite accurate model of our snake in the virtual world. And what we did is, okay, now instead of doing motion planning on the real snake, let's do motion planning in the animated snakes, because that's computer. We can do things very fast. So we use genetic algorithms to do that, where the genome is actually the commands we put to the motors. Go to 5 degrees, 6 degrees, 10 degrees. So we started evolving motions. Have the computer look for good motions. And what we did is we told the computer, a good motion is a motion that takes the snake from point A to point B the fastest way, and just go wild. So we had computers running with multiple parallel core throughout the nights, running millions of evolutions, validating those evolutions in the computer in the digital twin, not in the physical robot, because in the physical robot you cannot do things fast. And this is an example of how motions starts to create it. It's like human, it's like animals, it's like creation. Babies that born, they move chaotically because their motion planner is starting to learn the connection between muscle activity and joint motion, and then motion starts to refine. And then we implemented this in the new generation of the robots. Excuse me, let's go back. Videos should work. No, doesn't. Yeah, they work. No, they don't work. Anyway, the snakes become very popular, and many people like to hold them and touch them, probably from the time of Garden of Eden and the snake in there. People just have a fear of snakes and like to talk about snakes. Anyway, remember I came from medical and surgical robotics. This was just a side project. And then I went to a conference on minimally invasive surgery, and a friend of mine, a surgeon from Italy, he was at Pittsburgh at that time, now he's in Harvard, showed this image when he used his talk, and he said, I'm doing minimally invasive surgery. I asked him, Marco, what's so minimally invasive here? So see how many holes you have here. It's more holes than, it's a lot of trauma. And he said, yes, I use it because I'm operating with chopsticks. I have a long stick with a tool at the distal end of the stick, and if something is blocking my way, if this is my entry point, and I want to reach this point, if something is blocking my way, I cannot go around it because I'm operating with a stick. I need to make a new hole, maybe to push things, to pull things. This is why I'm using so many holes. And then when I showed him the videos of the snakes I do, he said, why not shrink them down and use them for surgery? I said, well, why not? And this is our first take of a surgical snake, 1 centimeter in diameter, 10 millimeter in diameter, 50 centimeter long. And in 2005, we incorporated, we started a company called Robotics. And Robotics is creating these snake robots that crawl inside our body and perform surgery. And this is the principle of how the snake works. If the video works, if it doesn't work, I'll try and switch to another connector because it seems like a problem here. No, it doesn't. No. Well, some of the videos work, some of the videos don't work. Maybe because I'm using the HDMI, maybe I should use the VGA. No, they don't. Anyway, so Yeah, we'll try the next video. So the snake is actually penetrating the body of the patient through natural orifices or a single port that the surgeon is performing. This is the snake. The snake is one-time use. It's disposable. And after the snake crawls deep inside the patient, just same principle they did for search and rescue, okay? Very elegantly, without touching the environment. Once it's deep inside the patient, whether it's intracavity space or through a natural orifice, surgeon performed the surgery through the snake, introduces flexible tools that was not able to guide into the remote location inside the body and perform the surgery. And there's a wide portfolio of tools that the surgeons can use during surgery. This was a long journey, 8 years of regulations, regulatory FDA, CE marks, and this was the first robot ever to receive a robotic-assisted or surgical robot clearance from the FDA. All the other robots in the market, including the Mazor or the Da Vinci, are not considered robot by the eye of the FDA. And this is the first system ever to receive a surgical robot clearance from the FDA. As I said, they had to redesign their regulations. The system works worldwide now. We have hundreds of systems deployed around the world, companies based in the United States, in Wareham, Massachusetts. Just to give you an idea, about $350 million invested in development, in R&D, to reach the point where you start selling. So there's a lot of things after the science is done. So as I said, just to give you another example that what the system can do. No, the video doesn't. So some of the videos don't work here for some reason. Let me try and switch to VGA. Okay, so here you can see also the robots do sutures things, so you can do almost everything with the robot inside the patient's body. This is a tumor removed in the abdominal area with no opening, without opening the patients, because we did transrectal approach. We do transrectal, transvaginal, transoral, and transsubxiphoid for heart surgery. Any point, it's a flexible thing that goes inside the body, deep inside the body, and then through this device, you perform the surgery. So this is how the robot looks at the front. Again, stereo vision, and remember, this is 10 millimeter, or 1 centimeter. This is in diameter. Another nice project is a robot for knee surgery. This is a miniature bone attach. It's the same approach as the spine robot, but this is for knee surgery. And we designed it to actually prepare ourselves for the future. This is how knee surgery or knee replacement surgery is performed today. The surgeon is actually crowning or putting a metal joint on the sick joint, removing the bed cartilage and putting a metal joint. This is the new knee of the patient. This is where the cartilage was gone. This is where the disease was. And this is how surgery is performed today, and it's painful, very big, very traumatic. Now, and by the way, there's no problem for surgeons to do that because companies send them jigs and they know where to cut, very accurate, no problem, because the geometry of this implant is known. Someone designed it, someone did it. Problem starts when the new type of implants are starting to enter the market. The new implants are biological implants. These are cartilages that were grown up in a lab on a Petri plate, taken a sample from the same patients, and then returned to the patient, so no metal implants anymore. But this time, the geometry is not known. So surgeons become artists. They have to freehand sculpture the bone to fit the implant. So this is where robots are much more superior. By the way, this is how they do it. This is real. This is taken from Stryker instruction for surgeons. This is modern carpentry. And this is exactly a place where a robot is much more superior to the human hand. So what the robot is doing is attached to the bone rigidly. So the bone and the robot become one rigid body. And then the robot palpates or actually collects points from the surface of the bone. You can see here, collecting points with a force sensor, points and normal, so we can create now the surface that we want to work on. This is intra-operative planning. We're collecting the points at the same reference system that is going to do the operation, so no need for registration. For those of you who do registration, you know this is where the error is coming into the process. So you get a surface, and then you replace the palpating part, tip, with a burr that actually machined the bone now, just like a CNC machine would do in the machine shop. Now it's the same system that was collecting points, now is machining. What is the next step? Printing. So the next step we're working now in our lab is replacing the head now with a printer, with a 3D printer, with a jet. Printing now biological materials that are going to be developed into biological cartilages. We don't develop these materials, but we develop the platform. So I call it all-in-one. We have one robot that does scanning, machining, and now 3D printing. So this is the future of robotics. This is where robots really are much more superior to human hand. I mentioned gate analysis and biomechanics, so this is our gate lab. And we have 18 camera Vicon system and force plates and EMG and EEG sensors. We're quite equipped. And what the system is doing, for those of you who play FIFA on the computer, you should know that some students are laughing. The reason that the figures, the images in the games look very human is because they brought human, actual people in to play soccer, and they track their motion with this kind of tracking system. What we do is we put markers, reflectors on our subjects. These are reflectors. They reflect the light back. And when the camera sees, two cameras see the same one reflector, it knows to locate this reflector in the lab space with the accuracy of 0.1 millimeter. Very accurate. So what do we do with that is that we can now do motion tracking and analysis. This is a patient walking in our lab. You can see the motion, you can see the points. And we're using some math called screw theory. We like to use screw theory and line geometry. For those of you who work in kinematics or in motion or in transformation, Lie algebra probably sounds familiar for some of you. If you remember, you can, instead of using matrices to describe transformation and rotation, you can use a screw. A screw, or every transformation, can be described as a rotation and translation, both happening at the same time with respect to an arbitrary or some kind of axis in space. So this is the principle of this mathematics. But what it does, it actually breaks down, instead of looking at a matrix, you are actually looking at the basic principle of the motions. And when I said the basic principle of the motion, I see the twist is the ratio between the rotation and the translation. How much rotation and how much translation is in this motion? Where are the screws? Where are the axes of rotation? What is the intensity of the motion? So this is a very powerful tool for those who wants to understand, and I heard this morning some talks or yesterday, talking about the fact that deep learning, you get an answer, you don't understand the physics. Here, you actually understand the physics, because if I take matrices and I do deep learning, I might get the same results, but I will not understand the physics behind the results. Here I can understand the physics. So for example, for knee motion, these are the instantaneous axes of rotation of the motion of the knee from flexion to extension in a sample rate of 120 frames per second. So it gives me the motion or the notion where those axes are. Now if I take two successive axes and I connect the mutual normal to these axes, I get a striction curve. It's called striction curve. And if the striction curve is repeatable, I know that the motion is repeatable. So I have a tool to evaluate, to assess the motion, whether the motion is good or bad. Because remember, in engineering and in science, the biggest threat is to have trash coming in and trash coming out of your system. Because if you don't understand what's in the black box, you might have trash in and trash out. Here, it gives you actually a physical understanding and you can evaluate things. So where do we apply? We apply it in hip problem, knee problem, lower back problems. And remember that our body is a closed kinematic chain. So for those of you who do sports, if you ever twisted your ankle, your right ankle, you suddenly feel after a day or two that your left side hurts because it compensates. It compensates for the injured joint. So everything in our body is being compensated, and everything starts, by the way, at the foot, because this is where we come in contact with the environment. So we study a lot about the foot, what's happening in the foot, and it's a very complex mechanism, and you can see how we measure the footprint, so to say, or what we call the center of pressure of the foot, and how it translates in our foot, and it has a lot to do in biomechanics. And then we designed some kind of shoes with an Israeli company called Apos Therapy, and it's a shoe that has biomechanical elements that can be moved and locked in the sole of the shoe. And by doing that, we're actually moving these curves that you saw before, or the contact points with the ground. So what do we do with that? Okay, so we can control the forces that we apply on the floor. We can control everything that happens in the foot, and patients are sent back home to walk with these shoes. What we do is we treat patients with knee and hip osteoarthritis and low back pain. And we do that by understanding the pathophysiology of the disease. By the way, this is the #1 health concern in the United States and the Western world. Almost everyone over the age of 70 suffers from joints problem, and a lot of people actually end up in the operating room. The companies are making a fortune on that. And this is a bad knee. You see no cartilage here. And it turns out to be a mechanical failure. Look how many, $9 billion market a year. It's a huge market. And it turns out to be a purely mechanical problem, because when we walk, we apply force on the ground, and what we know from Newton is that the ground is applying forces on us, and these forces are starting to destroy our joints. And if we run a lot, we are even accelerating this process. And for you, those of you who remember physics, if there is a force, and there is a joint, and there is a lever arm between the force and the joint, the force is creating a torque on the joint, and this torque is actually the one destroying our joints. And understanding this and using the shoes, we said, okay, if this is the force, this is the joint, this is the lever arm of the force, creates a torque, and we know the torque is equal to the force times the distance to the joint. So we can reduce the torque by either reducing the force, which means what? How do you reduce the force? You either move to the moon or Mars, you volunteer, or you don't go to conferences where there is good food. You lose weight, which is not that easy, I can tell you, from personal experience. So what you could do is you can actually move the force. How do you move the force? With these kind of shoes. And this is what we did. You remove the force with the shoes, with moving those biomechanical elements. And we do it a very controlled way. This is 14 years of study. Many researchers, doctors, physicians, clinicians that work with us. And it changes, actually reprogram your brain to walk differently. Look at this lady. She's not an actress. This is a lady coming into the clinic. By the way, this is sold worldwide. This is day one. See how she's limping? She's suffering from knee osteoarthritis. And right after we put her on the shoes, see what happens. So actually what we did is we took the force from the bed compartment of the knee where the wound is, and we moved it to the other side of the knee where she doesn't feel the pain. Now she's sent back home, and we tell her to train. She's actually starting to reprogram her brain to walk differently. After 3 months of training, she comes to, this is after 1 month actually, she comes into the clinic, look how she walks. She walks different. And this is what happens to many patients. This is this product, or this treatment is sold worldwide in New York, Europe, and in Israel. And it actually changes and revolutionizes the treatment of patients with knee and hip problems and even lower spine. It also works on the hip. Let me show you just a video. This is the patient before. Look at the pelvic angle here. And look what happens after the treatment, after 3 months. It's an amazing, look also the green is the right leg. See, it doesn't flex much. And you can see here how much it's a free motion. So I said robotics, so what do we do now? The shoe is a mechanical shoe, and now we are roboticizing the shoe. So instead of having someone tuning the system, we put sensors inside, we measure the forces and where the patient walk and how it put the weight on the shoe, and put motors inside, and we are actually motorizing and controlling those elements robotically. So you just put the shoe, you start walking, and the shoe would do the job for you automatically. No need to see a physician or a clinician or an orthopedic surgeon. You don't buy it in a shoe store, you buy it in a clinic because you do need someone to follow up on you, but the shoe is completely robotic nowadays. Now you can start walking, and it's a vicious cycle. The comment is now we can start being overweight or lose our weight. Actually, we start losing our weight because this is, yeah, it's a joke, but ironically it's true, because patients who suffer pain don't walk. If you don't walk and you still there is an intake of food, you gain weight. You gain weight, you put more pressure, it hurts more. You walk less, much more less. Now, if the pain is gone, you start walking. You start losing weight. So it's a chicken and egg problem here. Let me show you another example of what we do with motion planning, motion tracking in respiratory observation of patients. This is a work we did with the Sorbonne in Paris, in Versailles, this is a hospital that deal with people with respiratory problems. So the only way to measure how much air is your intake today is using spirometry. It's a very, I would say, primitive tool that just measures how much air flows in, and that's it. You don't know where the air goes. So what we did is we took patients and we put those markers on their chest, okay? And we then created a mesh. This is something you guys know how to do because you're doing a lot of this. And each node in the mesh is one of those markers, reflectors. So we can track them online now. And we're using the same medical definitions of parts of the chest. Okay, we work with physicians. And then we apply math. And this is the point where I want to show you that we do some math. So we calculated the deformation gradient tensor of each of these triangles. Remember, each node of the triangle is a reflector. It's one of those sensors that we can measure. We can know where it is. So we measure the deformation gradient tensor, the translation vector, and then using some kind of polar decomposition, we split it into rotation, translation, volume. We get all these parameters that mathematically, and we do Gauss theorem and apply Gauss theorem to measure the total volume of air that goes inside. And at the end of the day, when we measure patients, this is what we get. Color code is reflecting the deformation, the stress, the strain. Actually, this is a tool coming from solid mechanics or continuum mechanics. Okay, I'm a mechanical engineer, by the way, by training. So you see, this is spontaneous breathing, and this is vital capacity. Vital capacity is when you blow a lot of air into your chest. You see, everything is under a lot of strain. Now, these are healthy people. Now, look at this patient. This is healthy. Do you see something ironically here? See, the chest is going up. The abdominal area is going down, backwards. These are pump patients. It's very hard to distinguish whether you're a pump patient. Sometimes it's hard to know if you're a pump patient at all or a Duchamp patient, as I show you in a minute. With this kind of tool, you do it very accurately. And you can track the patients because you can actually see very accurately how they breathe. This is the weakness of the diaphragm that causes this problem. Now, this is pump patient, and now this is Duchamp patients. Even much more complex. With these kind of tools, surgeons have very accurate tools to take the severity of the disease. So let's move on. Another work I was addressed by Ronit Wolstein. She's a physician. She's an expert in hand surgery in NYU. And she said that she was in Israel at that time, and she said that she sees a lot of young kids in Israel that have problems here because they train towards their army service. You know, in Israel, we serve 3 years in the army, and they do push-ups, and they hurt their wrist. Anyone here does push-ups? Don't be embarrassed. Very good. Very good. Are you doing some kind of martial art? Any one of you? They did this. So the question was whether this is better than this. Okay? Of course, the answer is yes, but the answer is yes because intuitively you know, but now scientifically I can tell you why. Now, pay attention for the video. So we had about 30 students is free almost, for experiments. All you give them is a pizza or I don't know, 10 euros per hour, and they do as much push-up as you want. You just go to the gym in the university and you collect them. So this is one of the students, and these are force plates. These are the plates that measure the force, the 3D forces that I apply on the floor. And I asked him to do push-ups. Look at the right, look at the left. This is one mode of push-ups, and this is the other mode of push-ups. Look at the arrow. The arrow is the forces that we apply on the floor. Do you see any difference on the right and on the left? You should notice that the one on the right is more wiggling. This is this mode, and the left is the one that you do in martial art. So when the forces less move from side to side, there are less shear forces that actually damage the soft tissue that causes the pain that you suffer when you go to the gym. Yes, sir? Everything was controlled. Yeah, everything is controlled. The distance between. No. Everything was controlled. Well, they did it the same configuration. Everything was controlled. Excellent question, but everything was controlled, and but the results are dramatic. Then you can import these measurements into finite element analysis, and you can measure which bones damage more and which ligaments, and these are things that you can do. I started 15 minutes later, so I'm almost done. I'm good with the time. If this is okay, 5 more minutes. This is another study by Yair. He's a PhD student here. We're working on grasping pattern and augmented reality, or in other words, we're trying to develop hand devices to give you force and tactile feedback. Not just that I touch something, but the texture of what I touch. And for every PhD work, it's not enough to build a nice device. You have to have some theory behind it and claims. So what Yair claims is that our grasp, the way we interpret the world, our grasp is patient-specific. Like many things now in medicine, everything is patient-specific, which means I grasp things different than Freddy is grasping. So to do that, we designed some kind of an experiment where we, again, 36 students, a lot of pizza in our lab. And what we did is we put the markers on their fingers, and we put also force sensors at the tip of their fingers, tiny force sensors, to measure how they grasp object. Of course, everything is controlled. They had to sit inside next to a table. Everything was marked on the table, and they had few objects to grasp. Eggs, soft one, hard one. It's a bowl. It looks like an egg. Okay, one was soft, one was hard. A bottle, one was full, one was empty, and a tennis ball. And this is the result. And this is a video of one of the subjects. So I think you can understand that this is a hand and these are the fingers. And what you see here under, these are the forces that the subject is applying on the object that it grasps. You can see that when the fingers are in touch with the object, there is an increase of force. So we took this and then we applied some of the methods I heard people talking about here before, TSNE and KNN, and we tried to do reduction and cluster analysis, and surprise, surprise, cluster analysis. Each graph here, these are different objects. Each color is a subject. So each subject had to repeat these grasps 7 times. We took all the 7 times the number of objects times the number of subjects. So we had a vector of 15 or 20,000 data, and we did just, cluster analysis, brute force. So what you see is that every subject has a cluster, which means that the system was able to identify people by the way they grasp each of the objects. Interesting, even more interesting, you remember we had a bottle which was full with water and a bottle which was empty. So you see the graph again? This is the graph where both the full bottle and empty bottle were overlaid at the same graph. So you see still patients are separated, but when you zoom in, you see the triangle and the red. Triangle and red dots. This is half, bottle which was empty and full. Within the cluster, you could see the full and half, and the full and empty bottle, which means that our grasp is a biometric. So maybe in the future, you'll go to your door, you grasp the handle to open the door, and there are going to be a set of sensors detect you and open the door for you because they know it's you. Okay? Or someone would do gait analysis and identify your gait because gait analysis is biometric too. Remember, if you walk in a twilight and you see your friend approaching you, and you don't see the friend, you don't see the face yet, but you see the silhouette of the patient, of the person, you know this is my friend because somehow the motion is known to you. And then we did the sensitivity analysis, and now we know which parameters are more important to grasp what. We do great analysis also to other things. This is something we did to barn owls, birds that have a very specific, very unique motion. It's called peering motion. They have a stereo vision like humans. We put the sensors on their head. By the way, everything is approved by ethical committees. We didn't do any harm for these birds. And we were testing their peering motion, which you're going to see in a minute. So it turns out that whenever something gets the eyes of the bird, it moves its head from side to side, it's kind of peering motion, like Freddie is doing right now. And we were, fascinated. You're going to see the peering motion in a second. It's very fast. There you go. This was side to side. There you go. This peering motion. We suspected, by the way, stereo vision, like humans, no eyeball motion. Eyeballs, because of the biology, eyeballs don't move. We suspected this is using almost like triangulation. The bird is trying to get extra data from the environment to somehow lock on target, because this is one of the best predator in nature. And so we measured lots of birds, actually 5 birds. We had close to 100 hours of recordings with the motion tracking system. And then we used the screw theory, line geometry, the same tools that I used before to try to break down the motions to the principle of the motion, to try to understand what distinguishes the motions and what defines the motions. Actually, we realized a few very interesting motions and observations, but then, as I said, robotics, we built a robot and we call it Barn Bot. A robot with a stereo camera. This was at the time where the Kinect was still the stereo camera available. And we actually had the robot copy the peering motion of the birds. And we compared the reconstruction of the environment with these peering motions to regular rastering motions, and reconstruction was much more better with the biomotions. More tools that we build are kind of robots that are inspired by worms. This is an inchworm locomotion of robots that does all kind of crazy motions, and you can shrink it down and send it to someone's body. This is a very nice project that I'm proud of. We're actually building robotic hands for children. This is a public domain that we have, so if you log into our servers, enabling the future, children that for some reason either lost their hands or are born without hands because of birth complications, we build robotic hands for them, and we get it for free. And we design it, we design the geometry, and everything is parametric, so you can scan. We design even a low-cost scan. By the way, everything here is bought from Alibaba. So this is the goal, low-cost hands, so people anywhere in the world can afford them. All the motors that we're using here are about $1 to $2 each. The controllers are, again, Chinese version of Arduino, the $1.50 Arduino. And believe me, from an engineering point of view, it's harder to work with this kind of things, equipment, than with the high end, because you need to really be very accurate in what you're doing. But then we give those hands to children and even to robots. So this is one of the hands we designed, and we got a donation from Alibaba Research in Israel, a robot, and we put the hand. This is Benjamin, you are the photographer here. So you can see the hand grasping an egg, and moving it from one side to another. You can see the fingers closing. Now, because we have sensors in the fingers, it doesn't crush the eggs because it knows where to stop. It will just fit itself like we do when we grasp objects. Now, these hands will be given to children. I'm almost done. We opened also lately a Center for Olympic Sport Research and a collaboration with the Israeli Olympics Center Authority. And we analyze athletes and help them understand more, or help them maybe bring more gold medals in the next Olympic Games, because there is a lot of science behind the sports. So it's not enough to do more push-ups. So you really need to, in this level, you need to understand the physics. So for example, how to tune the bicycle, the distance between the legs and the wheel and the athlete, so you can measure everything and optimize everything, and it's legal. Some people will call it technological doping, but dopes are illegal. This is legal. Everyone is doing that. Remember what happened in China, in Beijing, with the swimming suits in the Olympic pool? All the world records were broken because of this new swimming suit. People are complaining now about Nike with new shoes, maybe in the Olympic. And this is the last slide. Now we're show you that we're also working with weightlifters. This is a PhD student in our department. And we're tracking his motion. So it turns out that weightlifting is a very technical thing. So you can see the weightlifting here. You have to be very fast. And at some point, you need to catch the weight before it drops. And we're optimizing again, with motion capture system and optimization of what it does and trying to tell him, do this, do that. Now, everything that you see here is, of course, not possible without our PhD students. Where is Benjamin? Oh, I didn't put your picture yet, Benjamin. He is? Where are you? You're the, oh, right, you're the last one. So these are things that you can apply using all the methods that you heard here. You know, there is behind every nice video that you saw here, there's a lot of hours of mathematics and control and optimization and trying to understand really how to make it work, because what you see here in these videos, this is the folklore, this is the end results. You know, this is like the dancer. The dancer, before it dances, have a lot of hours, you know, training and suffering. So that's what I had to say, and thank you for inviting me and for your attention. If you have any question, I'll be here to answer. Thank you.